Hello everybody, welcome back to the channel. Today we're going to be talking about screening, which is part of our series of videos about the Periodic Health Checkup. As we've already talked about, the science behind periodic health checkups changes regularly. Doctors base their recommendations on the most recent scientific evidence. So in 2021, the Periodic Health Checkup has replaced the more traditional annual physical. Doctors no longer routinely examine asymptomatic patients in person. That's a bit like finding a needle in a haystack. Instead, the scientific evidence is pointing us towards a more targeted approach, screening for known diseases that we know we can impact at intervals that are neither too short nor too long. For some diseases, this may be 2 or 3 years or even longer. So today I'm going to be walking you through the diseases that we can screen for, assuming that you're a low risk or average risk individual. First, for high blood pressure. We screen people for high blood pressure starting at age 20 with a blood pressure check at least once a year. This blood pressure check can be done in the office or in the comfort of your home with a reliable and accurate home blood pressure cuff. Now, I encourage you to watch my video on why blood pressure is important and how to measure it at home, because it turns out that measuring your blood pressure is an art. And I'll provide a link for this video right here. The second thing we screen for is diabetes. We use the hemoglobin A1C method to screen for diabetes. Diabetes is defined as a hemoglobin A1C of over 6.5%, and pre-diabetes is defined as 6.0 to 6.4%. For both men and women, we start screening at age 40 if they're low risk or average risk, and we screen every 3 years. Now, for people with diabetes, we screen annually for things such as eye damage, kidney damage, or nerve damage. If you do have diabetes, then the target hemoglobin A1C becomes less than 7% for most people. If your hemoglobin A1C ever crosses over 8%, we might have to think about medications, and that's when you can come talk with me or talk with your own family physician. Third thing we screen for is your lipid panel, checking your cholesterol and your level of triglycerides or fat molecules in your blood. For men, we start to do this when they hit 40. For women, over 50. And that's really because the thing that we use the cholesterol to predict is your risk of cardiovascular disease or your risk of heart and stroke in the next 10 years. Unfortunately for men, that happens a lot earlier than it does for women. But the good news is, again, that you no longer need to fast for this test. Now, what we do with your cholesterol numbers is we input those numbers along with a variety of other risk factors into cardiovascular disease risk calculators. And this calculator will predict your risk of cardiovascular disease in the next 10 years. And that's what we use to decide whether you need a statin medication to lower your cholesterol or not. The fourth thing that we screen for is colorectal cancer. Colorectal cancer is something that affects all people. In Calgary, Alberta, the way we screen for this in the average risk population is with a FIT test, a fecal immunohistochemical test. That's usually done every 1 to 2 years. It doesn't need to be precisely at the 1 year or 2 year mark. If the test is positive, it means that you have slight traces of blood in your poo, and we should send you for colonoscopy. We screen everybody between age 50 to 74. And if you're at higher risk, make sure to talk to your doctor about when to get started screening, because it could be a lot earlier. The other thing that we consider screening for is for low bone density or osteoporosis. Osteoporosis is something that can highly increase your risk of having a broken bone, especially when you age, and that's no good. We screen everybody at least once with a bone density scan when they hit age 65 or more. If somebody has a higher risk for having a fracture or having low bone density, then we screen them at age 50. The result of your bone density scan is used in combination with all your other risk factors to calculate your risk of having a fracture. And again, that risk is what we use to determine whether you can benefit from a medication or not. Next, in women, we screen for 2 more cancers, cervical cancer and breast cancer. Cervical cancer is caused by a virus called HPV, the human papilloma virus, and there's hundreds and hundreds of different strains of HPV that can affect you. Fortunately, we can screen for this early by doing something called the Pap test. For low or average risk individuals, we recommend the Pap test every 3 years, and we start 3 years after your first sexual encounter or age 25, whichever is later. Now, you might notice that the average age for having these Pap smears has become later and later. The reason is because more and more data is telling us that younger people are able to spontaneously clear the HPV virus, whereas older people are less able to do so. So there's no screening under age 21 anymore, and by age 70, we usually stop if 3 of your Pap smears have been negative in the years preceding it. For breast cancer, we screen with a tool called the mammogram, which is basically an x-ray of the breasts. We don't do any screening before age 40 for the average or low risk individual. If you're age 40 to 49, the risk of overscreening might actually be greater than the benefit of screening. So it's always a personal decision whether you want to be screened or not. But if you are, we need to screen you every 1 year. If you're over age 50 and under age 74, then we screen you every 2 years. And that's because the older you are, the slower that breast cancer tends to grow. After age 75, it becomes an individual decision whether to screen or not screen. The last type of cancer that we may or may not screen for is prostate cancer. Prostate cancer used to be screened with a blood test called PSA, the prostate-specific antigen. The PSA test, we've learned over the years, is actually quite a non-specific test. It has a high risk of false positives. We also know that the PSA tests don't really prolong life. The PSA test will prevent 1 in 1,000 deaths because of prostate cancer. But 4 out of 1,000 people will also suffer from unnecessary biopsy complications from a false positive, and those complications can be life-threatening. And we also know that 5 out of 1,000 people will die from prostate cancer despite PSA testing. Of course, we also used to screen for prostate cancer with the old finger up the bum exam or the digital rectal exam. Now here's where I joke with my patients. I took over their care from other family doctors with much thicker fingers than I have. And so they're actually quite lucky to have me as their family physician. Jokes aside though, the fact is, when we reach up the bum to feel the prostate, we can only feel less than a third of the prostate. So it's not really that useful to detect prostate cancer. We do the finger up the bum exam if you have bleeding from your bum, if you have new symptoms of enlarged prostate such as dribbling, hesitancy, difficulty peeing, peeing again after you just went peeing. We also would do the finger up the bum exam if we think you have prostatitis, so an infection of your prostate, or if you are at a high risk for prostate cancer, such as if you're African American, African Canadian, if you have a family history of prostate cancer, or if you have prostate cancer before. Overall, it's your choice whether you want to get screened for prostate cancer or not. But just know that we don't have good tools to screen for prostate cancer right now, and that most men die with prostate cancer instead of prostate cancer. If you do want to be screened for prostate cancer, screening starts after age 50, and you can let me know, or you can let your family doctor know. Of course, if you're high risk for prostate cancer, like if you're African Canadian, African American, if you're obese, or if you have a family history of prostate cancer, we should probably screen you. For my patients that decide to get prostate cancer screening, I usually do a PSA once every 2 or 3 years or so. And if a PSA test ever comes back positive, then we'll repeat it in about 2 or 3 months. We don't need to worry right away about one high PSA test. And that's it for our video about the screening methods that are done in a typical family doctor's office. Now before we conclude, I do have to correct one misinterpretation. Screening is not about cost savings or about physician laziness. It is an objective, scientifically backed way for us to benefit our patients' lives. Why is screening important? Well, during COVID, I've been told by my palliative care colleagues that we're missing up to 30% of cancer cases, likely because patients aren't coming in for their preventative screening. This one example just goes to show how many lives we can benefit from everyday screening procedures. Now, science is always improving, so make sure to check in with your family doctor for the latest updates. That's it for today, everybody. Take care and stay healthy. Keep in mind that everything we talked about in this video has been for the low or average risk individual, and none of this is medical advice. If you think you're at higher risk, or if you're looking for medical advice, please talk with your family physician. We're always here for you.